a new system of prevention and treatment of ischemic stroke in Poland. It's rather an evolving concept that I like to present, and I think many things that I will present are not new, but this is how we try to improve the results. So stroke in Poland, is it a problem? Yes, it is. The yearly incidence is about 65 to 70,000, and of course it is the source of significant mortality, morbidity, and socioeconomic burden. When we look at the curves, the red one, this is the stroke-related mortality, or mortality to all cerebrovascular diseases in Poland, and we can see that it had been increasing to late 90s. In the past, it seemed that it was even lower than the numbers in European Union, but maybe it was underreported. I don't know. But there was a very bad tendency of growth of mortality, and fortunately, in the late 90s, it was reversed, and the mortality of cerebrovascular diseases is decreasing and parallels the European curve, though it's still something to be achieved. When we look and when we think about how can we decrease stroke-related mortality, there are many factors. I think there's decreasing stroke incidence that can be achieved by risk factor modification treatment. There's a known role of statins that have been mentioned in this meeting today, and treatment of causative diseases like anticoagulation, patients with atrial fibrillation, that was also discussed, in treatment of carotid stenosis. And of course, better stroke treatment may lead to decreased mortality. So with regards to the risk factor modification, this is what we observe in Poland. It's a good trend of a decreasing number of regular daily smokers in a population over 15 years of age, though it's still higher than in European Union altogether. But of course, the effect will be, the beneficial effect of this, I think, would be delayed. It's not right away. So I think that probably the most important factor responsible for decreasing number of stroke-related mortality in Poland is better treatment. We can see that the number of hospital discharges due to cerebrovascular diseases increased and sort of catch up with the European numbers, and this may represent on one way the maybe greater number of carotid endarterectomies and carotid intervention, but I think most it represents the fact that most of the patients with stroke are treated in hospitals. And when we look more closely, it's not only hospital treatment, but a well-organized and good hospital treatment is important. And in 1997, a national network of stroke units was initiated in Poland. And in 2000, a national program of prophylaxis and treatment of stroke issued a project of stroke unit. And the project comprised 120 stroke units nationwide, with coverage area of 80 kilometers of radius that would allow for transport less than 2 hours. And there are many requirements. I think the most important is minimum 3 intensive care unit beds in unit and 24 hours, 7 days availability of CT or magnetic resonance imaging and laboratory. And as we can see, the number of stroke units was increasing, and in 2012 it was 150. So we can say that the project, the program was fulfilled, and also increased the number of stroke units fulfilling all the criteria. So the next thing that is important are the guidelines and the neurologists, they have their guidelines. They are published, they are updated every several years, and it's important that stroke is considered as a medical emergency and should be treated in a stroke treatment unit. So prompt diagnosis and admission to stroke unit is essential, and that implies education of the society, because the prompt diagnosis cannot be made by a doctor. It should be made by the patient himself, his family, or the people in the street. And of course, education and training of medical personnel, of the rescue teams, with regards to the proper transplantation, and also the proper history taking, especially with regards to the onset of symptoms. And then the next thing at the hospital or at the stroke unit is rapid diagnosis of type of stroke with CT, MRI, and in case of clinically relevant ischemic stroke, qualification for thrombolytic therapy. Nowadays, the thrombolytic therapy is mainly the intravenous therapy, and when we look at the guidelines, they also evolves. Well, what is constant is our indication, like clinically diagnosed stroke, or TIA in some patients with significant neurologic deficit, exclusion of intracranial hemorrhage, duration of symptoms at least 30 minutes without improvement. But what has changed is the maximal duration of symptoms from 3 hours in 208 to 4.5 hours in 2012, and it's likely that even that time frame will be increased to 6 hours. And age, in 2008, there was age limit of 8 years of age, and nowadays they don't have that age limit. And of course, what is necessary is absence of contraindication for thrombolytic therapy, and the list is very long. That's why I think it's known to everybody. I didn't put it here. And thrombolytic therapy, as I said, is intravenous with RTPA, with the total dose 0.9 milligram per kilogram of body weight, but not exceeding 90 milligram, and total 10% in IV bolus injection during the first 2 minutes, and the rest in 1 hour IV infusion. Blood pressure management in patients receiving thrombolytic treatment. The hypertension is not treated unless it's more than 185 on systolic and more than 110 on diastolic. And in other patients, except for patients with acute MI or aortic dissection, even higher values are accepted. And of course, the low molecular weight heparin is given as a prophylactic against venous thromboembolism. And the next step in the stroke unit is diagnosis of cause of stroke during the same hospitalization, which is mainly duplex Doppler of extracranial carotid and vertebral arteries, transcranial Doppler, transthoracic echocardiography, and ECG. And this is the end of the guidelines. And actually, there's absence of formal association between stroke units and vascular surgery units, and this is something we're going to work on in a district of province of Poland that's called Great Poland, and where I live and work, and with the Poznań, the city that's capital of that, and this area is inhabited by 3,500,000 people, and nowadays there are altogether 15 stroke units in that area, 3 in Poznań city, and the rest in the smaller towns. So the purpose of the project is to increase the number of early carotid endarterectomies in patients with symptomatic carotid arterial stenosis, and decrease the interval between an index event and CEA. So the preliminary qualification is done in a stroke unit based on the data that they routinely use, duplex Doppler CT, neurologic assessment, mainly with the ranking scale, which is important, and pharmacotherapy is initiated with acetylsalicylic acid and statins. And this is the modified ranking scale. And to make it simple, I think the most important thing is ability to walk. If the patient is able to walk independently, he's not. It means that this is within 1 to 3, and if he can't walk, it's more than 3. And this is something that precludes early or makes it unjustified early or any intervention. So these are the inclusion criteria that we have: diagnosed TIA stroke, stenosis of internal carotid artery higher than 70%, and selected patients with a very unstable plaque and crescendo TIA more than 50%. Absence of intracranial hemorrhage, general status as an ASA scale not higher than 2, and ranking scale not higher than 3. And exclusion: major neurological deficit, brain infarct bigger than 3 centimeters in CT, and patient unfit for surgery. So at the admission to our department, everything is verified, the carotid stenosis is verified, the neurological status and fitness for surgery are verified, and pharmacotherapy is continued. And the procedure is the preferred type of anesthesia in our unit is local regional anesthesia with selective shunting, and general anesthesia with routine shunting allowed if local regional not possible. Intraoperatively, patient is given unfractionated heparin, 100 units per kilogram of body weight before clamping of common carotid artery. Partial ablation endarterectomy, it's at the discretion of the performing surgeon, and intraoperative monitoring of brain function, most of all assessment of verbal contact with the patient and assessment of motoric function. And probably we haven't done it yet, but we will also use evoked potential and follow up on the first postoperative day, an intermediate care unit, monitoring of vital signs and neurological status, blood pressure, with the systolic blood pressure within the 110, 150, assessment of troponin and seroactive protein, and discharge from the hospital the second postoperative day if no complication. And then follow up in outpatient clinic. And this is the beginning. So far we have started the collaboration with 2 stroke units only, and so far we operated on 28 patients with recent TIA or minor stroke, with mean age of 69 years, mean ranking scale 2, ranging from 1 to 3, and mean duration of symptoms 19 days, which is long, and this is something we have to work on. Most of the patient, is 27 was operated under local regional anesthesia, and the 1 under general anesthesia, and 2 patients required intraoperative shunting, 1 from GA anesthesia and 1 from LA anesthesia. And in those 30 patients, the results that we had were very encouraging. We did not observe recurrent TIA stroke, no death, no MI, and neurologic status was improved or stable within the first 30 days. So the preliminary conclusion is that recent TIA minor stroke in selected patient does not increase the risk of carotid endarterectomy, and further effort is required to shorten the time interval between the index event and carotid endarterectomy. Though looking at this patient, we didn't have any patient that suffered recurrent stroke with TIA while awaiting the surgery. So maybe it was good luck. Maybe this time period is good enough. Thank you again.
Пожалуйста, вопросы? Нет вопросов.